morning, everyone.
Good morning.
Hi, I'm Ayush, and I'm going to do the opening remarks for the session. So let me start with a funny observation I had. We are one of the most advanced medical facilities in the country on a Wednesday morning, discussing why 60 million Americans can't get primary basic care. So it made me think like it's like holding a food security conference at a Michelin-starred restaurant, isn't it? So, though in fairness, I'd say to Vanderbilt that this is an institution, of course, that actually walks the talk on this. So, we are honored to be here. Nothing to take away from them. And a genuine thank you to the BRI event team for putting this event together harder than it looks. Why not we do a round of applause and some positivity to the Well, I've been to a lot of health conferences and I've noticed something. We are very good at agreeing that the rural health crisis is real. We agree about it over breakfast. We agree about it during the panel. We agree about it at the networking break. And then we do go home. But I believe that this room is going to be different, or at least that's what I tell myself every Wednesday. So now let's get to work. I want to start with one number. 46% of the rural hospitals are running a negative operating margin. Not a thin margin, but actually negative margin. That's not a management crisis. That's a payment model crisis dressed up as a management crisis. Thank you. And here is what it leads to. 59% of rural hospitals no longer offer labor and delivery. Since 2020, over 116 maternity units have closed. In 2025, 27 shut down. So, have rural women stopped needing to give birth? No, right? But because the reimbursement for a delivery in rural Medicaid-heavy population doesn't cover the cost of keeping an OB on 24/7 call. So the hospital does the math. A delivery unit needs a physician available around the clock on a Medicaid reimbursement rate that hasn't kept pace. And so they close the unit. The nearest hospital today is 60, 70, 80 miles away, and some of these mothers don't even make it in time. We call it the rural-urban health gap. The people living it call it a Tuesday. That's not some abstraction, that's what a broken payment model looks like when it lands on a real family. But we have hope, that's why we are here. So here's what is different in 2026. And I say this carefully because I've seen a lot of time that this time it is different moments in healthcare that it wasn't. But something is generally shifting. $50 billion in federal investment specifically for rural health transformation, not a pilot, not a demonstration project, but actual money going to actual states with an actual mandate to change how rural healthcare is delivered. Now, I'm not going to stand here and tell you that the federal government has got it solved because then this will be a very short conference. But what I can say is that the money exists, the policy framework exists, telehealth infrastructure is going up from even, like when I speak with clinicians, they can tell that change is happening on the ground. But what's been missing is the execution layer, enabling the organizations in room like this one, who know how to turn a federal mandate into a care model that actually works for a patient who is 80 miles away. So states have funds, but most don't have the playbook, and I believe that's what this room is for. I believe there are three things that will determine why today matters and whether do we all go home, agree rural health is a crisis, and do it next year again, or do we make a difference? The first is workforce. Because you cannot staff your way to safety with locum tenens and travel nurses. The communities that will win are the ones building real pipelines through your programs, partnership with regional medical schools, incentive structures that make a rural posting a career advantage and not a career sacrifice. That takes 5 to 10 years, but it has to start now. Second, the reimbursement literacy. Every clinical leader in this room will need to understand that their revenue at the billing code level. APCM, RPM, CCM, the CMS Access that has just got launched. These aren't just compliance acronyms. These are survival tools. If your organization isn't prioritizing every reimbursement pathway available, then you're leaving money on the table that actually your community cannot afford to use. And third, the technology that actually works for clinicians, not against them. We are losing clinicians not because they don't care about patients, but because the system they work is exhausting. A physician spends 2 hours on documentation for every 1 hour of patient care, clicking through screens that don't talk to each other, entering the same data in 3 places, and chasing prior authorization at 9 p.m. That's not a technology problem, that's a design problem, and it's a retention problem, and eventually that leads to a patient access problem. Because when the physician burns out and leaves, he leaves behind 800 patients on the panel without having a doctor attending. Well, every EHR vendor will tell you that they have a rural solution, and they do. It was built for a 500-bed academic medical center, and then someone removed some features and then called it rural. I believe some of you may have lived through that. The technology we need in rural healthcare isn't more sophisticated. It's going to be more humane. Systems that remove the mundane, so clinicians can do the work they are actually trained for. So workforce reimbursement technology that works. Pull one out and the other to collapse. So before I introduce today's speakers, a few pro tips to make the most out of the conference time. 1, talk to the person next to you, not during the sessions, after them. The best thing that will happen to you won't be on the agenda, it will be coming from the conversations in the hallway. 2, take 1 note, just 1, not 17. One thing you're going to do differently when you get that. If you leave today with 17 action points, you'll do 0 of them, 1 is achievable. 3, when the speaker asks any questions and there's an awkward silence, and I've seen that all the time, just ask the question. You know, everyone in the room has it, and you'll be a hero. And 4, when someone follows up with you later after the conference, do respond. It's revolutionary, right? So now for today's agenda, we have an exceptional lineup, let me tell you. Physicians who have actually practiced in the communities we are talking about, state officials, managed care leaders, researchers, people who are building value care models right now in rural settings that are actually working. We covered the full map today: workforce, reimbursement, AI community partnerships, RPM, value-based care, clinically integrated networks. So if rural health transformation has a gap in it, I believe someone in the room is covering it. We start this morning with the state of rural health, the honest picture, and then we get into the state about the workforce. Then Dr. Shah Khan and I will be on the stage talking about chronic care revenue model, which hospitals are leaving on the table. Then there is AI and aging, managed care, value-based care operations. You get the full out. Every session today is a different piece of the same answer, but where I believe that we will all of it to put it all together. And these are the people of it. Well, I started with a lot of numbers and stats, so let me end with something that isn't a number. As we get started on the conference, remember, rural health is not a niche issue. It's not a charity case. It's not somebody else's problem. It's 25% of this country living with a system that was never designed for them. We have the money, we have the tools, we have the people. They are all in this room. So what we need is the will to stop agreeing about it over coffee and start doing something. Today is a great day for that start. Welcome, everyone.